All right. So I know that Danielle just gave you my intro and told you a little bit about me. So let's talk a little bit about what exactly a midwife is. So midwives are trained health professionals, sometimes nurses, sometimes other health professionals, sometimes even people from outside of nursing or medicine that do private education to become a healthcare provider. I am a certified nurse midwife, but what midwives do essentially is take care of women all throughout their lifespan. So, from teenage years all the way through postmenopausal years. I think what most people commonly think of a midwife as is someone who helps women through labor and delivery, through the birth of their baby and postpartum. But we really actually do much more than that. So, a certified nurse midwife, which is what I am, is board certified in both nursing and midwifery. So, we have RN training, and then we go on to an advanced degree, either a master's degree or a doctoral degree, to receive advanced training. We do both obstetrics and gynecology to women of all ages. Essentially, midwife means with woman, right? It's an old, everyone always says to me, like, why that's such a horrible name, why don't you guys change the name midwife? But really, from many years back in the English language, it simply means like with woman. So it's really very fitting in terms of the title, and I love it now. And when I first started, I thought it was a little corny, and now that's really what we do best, is we just stay with women and we help them throughout the challenges that they feel throughout their lives. Midwives are not doulas, and I want to make that very clear because I get that question all the time. So, are you a doula also? So, a doula is someone who is really well trained in the very special art of labor support. And midwives are trained in labor support as well, but midwives make all the medical decisions. So we're really trained in the medical nursing decision making process, and doulas don't have medical training. They're actually trained specifically in labor support. So they provide a lot of comfort, and we make the medical decision makings. We do the medical decision making. So what's the difference between a midwife and a doctor then, right? If we do all the medical decision making. So the training is a little bit different. So physicians go to 4 years of medical school, and then they do a residency, and then they specialize in obstetrics. Midwives go to school for midwifery, and we do sort of our clinical rotations and our residency per se during the same time that we're in school. So while physicians go to medical school for 4 years, midwives go for about 2.5. And physicians sort of rotate through all the different areas of medicine and then specialize in obstetrics, where midwives go directly into women's health care, obstetrics and gynecology. And then, sometimes do some additional rotations. I did mine in the trauma bay at the emergency room at the University of Pennsylvania. That was an additional rotation for me. So, and a physician in the event of a C-section is the primary surgeon. Midwives are not surgeons. You can receive extra training as a surgical first assistant, and that's what I do. So any of my patients that need to have a C-section, it's the physician that does the surgery, and I'm the surgical first assistant. So for continuity of care, I can stay with the patient. And the model of care is just a little bit different. So physicians kind of look at pregnancy, labor, delivery, all the things that happen to a woman, menopause, perimenopause, often not as naturally sort of life occurring events, but things that sometimes need to be fixed, right? Where midwives tend to look at all of those things as very normal, naturally occurring events that may need some intervention, but really they need a lot of education and a lot of support. So the paths that we take to sort of treat patients tend to be a little bit different. We may end up in the same place. Physician and midwife may end up with the same medications, the same procedures, but I think midwives are really skilled at sort of looking at the entire person, looking at the entire patient, and being able to say, I really know this woman. Here's what I think might be able to help her along the way. So that's a very distinct difference. So let's get into our topics. I just called this Pregnancy 101, Basics for a Healthy Pregnancy. Some of these things sound really simple, but they're lifestyle changes for many of us because we don't always have a great diet. We don't always exercise all the time. So, as far as nutrition is concerned, whether you're looking to conceive and you're not pregnant yet, or you're newly pregnant, or you're in your second or third trimester, you are what you eat. Your baby becomes what you eat. So your nutrition is really, really, really important. I always tell my patients, eat all the colors, right? If you think about making your diet very varied in color, you're never going to go wrong. So think about, your yellows, your yellow vegetables, your green vegetables, your red vegetables, right? So eat a wide variety of foods. As far as sugar, we try to cut back a little bit on sugar or I always tell patients, sugar's like the devil. If you can get out all excess table sugar, you will feel healthier within a week and a half of starting it, guaranteed. So table sugar out the window, horrible. But when you're talking about natural sugars, right? Again, eat all the colors. Think about your apples, your bananas, right? Your green apples, all of your fruits and vegetables. Hydration. I always say water, water, water. I laugh because my husband tells me all the time, you went through so much education and you tell people to drink water and put their feet up all the time. And it's absolutely true because women have extraordinary water needs, right? Hydration needs in pregnancy. So when you're urinating, you should be urinating almost clear with the faintest hint of yellow from your prenatal vitamin. That's how you know you're getting enough water. So if you look at your urine, you look down into the toilet and your urine is actually a pretty deep sort of iced tea color, you are way behind on your fluids. So your water is super, super important. Exercise. I don't need to tell you guys this. This is stuff right? Exercise 20 to 30 minutes. Every day would be ideal. I'd be happy if I could get 4 to 5 days a week out of my patients. So think about those 10,000 steps, right? 10,000 steps every day. Most of us are walking around like attached to these all day long. And the truth is, they count our steps for us. So look on the health app and count your steps. Try to get 10,000 in on most days of the week. The biggest part, I think, of pregnancy and having a really healthy pregnancy is stress management. Think about the last 18 months to 2 years of our lives. Have you not been more stressed during this time? I certainly have. I think we're all, living with a lot more stress during this pandemic. And then we tend to overthink. Women are really, really good at overthinking. We overthink everything. Is the baby moving? When was the last time the baby moved? I'm not sure if I felt the baby move. Oh my God, what's happening if I don't feel the baby move? You see how you can get on the hamster wheel in your brain and it just doesn't stop? Try not to overthink your pregnancy. Your baby, I promise you, is never safer than it is when it's inside your uterus. That is the absolute 100% safest place for your baby. And I think that oftentimes, because we don't have a window that we can look down and open up and say, hi, are you okay in there? We really start to worry and get concerned that something might be wrong. And truthfully, understand that baby is the safest when it's inside. And the fact that we can't see it doesn't mean that something's wrong. Really, babies have a way of communicating with us, and that's through movement. So truthfully, you don't feel baby move very well until about 22 to 23 weeks, maybe even a week or two after that of pregnancy. So all of that lends itself to a little bit of anxiety on the earlier side. But if you're not having bleeding and you're not having excessive cramping and bleeding together, even if you're not feeling movement, the likelihood is that everything's fine. So stress management is like really important. So make sure, let me flip back. Make sure that you are taking time to manage your expectations of pregnancy and birth. I have so many women that come in, and Jackie, who's the other midwife here, Jackie and I, often start training. I want to say training, but really start counseling patients early on in their pregnancy to not have sort of the ideal birth in their head, because we don't know what the ideal birth is until we fast forward 9 months to the delivery room and we're trying to navigate whatever the situation is. So I think sort of coming in to labor and delivery, or your birth experience with a very sort of flexible mind is really paramount to you having a good birth experience. So many, many women will come in and say, I want XYZ, right? I want a natural birth. I don't want any episiotomy. I don't want my partner to ever leave my side. Right. And you hear how this is how it's going to be. And 30 years of doing this has taught me that the universe will always teach you something different. So I really feel like coming into your labor experience with very flexible, sort of realistic expectations. Sometimes things don't go like we planned. Right? Like that happens all the time. Sometimes things just don't go the way that we think that they're supposed to go. So I think that being open and understanding that your healthcare provider is there to help you, and you need to trust the person taking care of you. If you feel like you don't trust the person that you chose to help manage your pregnancy, then you might not be with the right person. So that's important also. You really should feel like, I trust Dr. So and so, or I trust my midwife, and they're not going to lead me down the wrong path, right? That in your gut has to ring very true. So, really kind of manage those expectations and enjoy your pregnancy. It should never be a time where you feel completely stressed, for 9 straight months. It's not healthy for anybody. Make sure you try and enjoy the time. So let's talk about first trimester, common discomforts, right? What's happening in the first trimester? Your uterus is now coming out of the pelvis and it's starting to come into the abdomen. So it's starting to enlarge, which, gives you a feeling oftentimes like I have to urinate quite frequently. That's quite common. Baby is starting to form. All the vital organ systems are starting to form on the baby. So here's what's normal: cramping. Your uterus is enlarging. So cramping is normal. It's not something to be overly concerned about. As your uterus enlarges, cramping is sort of a part of that. It is completely normal to have nausea, to have vomiting, to have breast tenderness, to be completely happy one part of the day and then be in complete tears later in that part of the day. Really wide mood swings, completely normal. You could also feel like, I am so tired, like I put my mascara on in the morning and I feel like I need a nap. Exhaustion, right? That kind of fatigue is very, very common. Weight gain or sometimes even weight loss in the first trimester, quite common. Food aversions. You might love chicken most days when you're not pregnant, but the minute that test is positive, you can't even stomach the idea of having a piece of chicken. Totally normal, nothing to be concerned about. You also might feel your heart beating really quickly. Sometimes people will say, I hear my heart beating in my ear. Is that normal? Yeah, there's so much extra fluid volume that's circulating in your body that your heart has to kind of catch up sometimes. So those little flutters that you feel in your heart, you are not having a heart attack. Your heart is not going to stop. It's really just physiologic adaptations to pregnancy. Here's what's not normal. So vaginal bleeding like a period at any time in pregnancy is never normal, right? Any kind of severe pain, any kind of fever over 101, not normal in pregnancy. Painful urination. Those are reasons to call your provider. I would also probably say in the first trimester, if you have cramping and bleeding together, even if it's not bright red like a period, could be like pinkish spotting, you'd want to call your provider for that as well. So think about your caloric needs in pregnancy. It's not a lot. I mean, most of us eat way more than we need to eat in pregnancy. And that's why some women are looking at 40, 50, 60 pounds in terms of weight gain, because everyone around you is saying you're eating for 2. So go ahead and have another piece of cake or take 2 cookies. But really, you're eating for like 1.25. So 300 additional calories a day is what you're looking at to maintain a healthy pregnancy. It's like a container of yogurt, right? Think about that. It's not really that much over and above what you normally eat. And so how do you deal with like all of these, symptoms that make us feel so much like garbage in the first trimester? So, nausea, vitamin B6 can be really helpful. 50 milligrams. I think I put 50 m's. I just realized my typo. 50 milligrams a day, super helpful. wonderful. Exercise, even to push through the fatigue. Get out, take a 20-minute walk, head to the gym, get on a treadmill for 20 minutes, kind of try to fight through that exhaustion. And I guarantee you're probably going to feel better at the end of it. It's a short period of time, although when you feel really horrible, 13 weeks can feel like a really long time. So you want to try to exercise. There's some great meditations. If you look on YouTube, there's some great sleep meditations if you're having trouble sleeping. There's a sleep hypnotist. His name is Jason Stevenson. He's fabulous. He's got probably 50 or 60 sleep meditations that I recommend to my patients all the time for sometimes the first trimester insomnia that happens. Make sure that your meals are a little bit smaller than usual. And make sure, again, water, 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 always adequate hydration. Okay, so what do you do in the first trimester? You're going to make your appointment with your OB provider, whether that be a physician or a nurse midwife. You want to start considering genetic testing. We're going to talk a little bit more about that shortly. You want to check your health insurance, right? Start to create a budget as you start to move through pregnancy, because you are going to be out of work for some time. Make sure you're eating right, cut down on caffeine. March of Dimes says about 8 ounces of caffeine is what's considered acceptable in pregnancy. If you're a big coffee drinker, big Starbucks, big Dunkin' Donuts drinker, you got to try to, bring it down to the small cup of coffee instead of that huge one throughout the day. And remember, chocolate has caffeine in it. So think about it. Tea has caffeine in it. So you have to really kind of work to lower your caffeine intake. Make time for fitness. Can't stress that enough. Sex is absolutely okay. Now, this slide says the first trimester, but sex is okay throughout your entire pregnancy if you don't have any complications. If you have a low risk pregnancy, sex is totally fine. And then when do you tell the world your big news? If you're talking to Dr. Giambalvo here, I tell people you really want to kind of hold that information in until after 11 to 12 weeks. Usually if miscarriage is going to happen, it's going to happen prior to like 9 to 10 weeks. And then usually at 11 to 12 weeks, we have some genetic testing. And then once we know that genetic testing looks normal, I feel like you can scream it from the rooftops at that point. The reality is that once we see a baby on an ultrasound that has a heartbeat, the risk of miscarriage is less than 3%. But it's very hard to go out and then have to undo your excitement, right? If you tell the world that you're pregnant at 6 weeks or 7 weeks, or when the test turns positive, and then you have to go back and tell the world that you're not pregnant anymore, that's really difficult. So I usually recommend not sort of telling anybody until 11 to 13 weeks, somewhere in that time frame. So let's talk a brief minute about genetic testing. There are several genetic tests. So one of them is called an NIPT, which just stands for non-invasive prenatal testing. It is a blood test that determines your risk for having a baby with chromosomal abnormalities. It looks at very small pieces of DNA. It's really remarkable that with every pregnancy a woman has, whether it turns out to be a live birth or a miscarriage, a little bit of that fetus's DNA remains in the bloodstream. It's pretty remarkable how that happens. So what it's looking at, the non-invasive prenatal testing, also called cell-free DNA testing. So, a couple different names for the same test. It's looking at little pieces of DNA from the placenta that are pregnant in a pregnant woman's blood. And so from that, we're able to say, again, you're either at high risk or low risk. It's not a diagnostic test. It's a screening test only. So it'll assess levels of risk. If you're considered to be at high risk for having a baby with a chromosomal abnormality, most common is Down syndrome, follow-up diagnostic testing is available to you if you so choose. So all of these genetic tests are optional. None of them are mandatory. So genetic carrier screening. What is that? That is essentially looking to see if mom meaning the patient, is a carrier for certain genetic diseases. The American College of OBGYN recommends that these tests are offered to patients. Again, they're optional. So the most common that are going to be offered to you are cystic fibrosis, spinal muscular atrophy, Fragile X syndrome. Those are the most commonly tested, but there are expanded panels that can test for up to 200 plus or more diseases to see if mom is a carrier. Now, if mom is a carrier for any disease, then we would ask dad to be tested as well, right? So we would ask mom to be tested, and then if mom's a carrier, father of the baby gets tested as well. If both parents are carriers for the same genetic disease, there is a chance that baby could be affected by disease. Only about a 50% chance, but it's still a chance. Then genetic counseling is offered to the parents to see what further testing might look like. There's also, if you have any history of Eastern European Jewish ancestry, there's an entire panel called an Ashkenazi Jewish panel, again, looking to see if you're a carrier for certain diseases. And then same, we would ask your partner to be tested as well. So again, nuchal translucency and also called first trimester screening is a two-part test. Nuchal translucency is an ultrasound that looks at the back of a baby's neck and takes a small measurement of that area behind the baby's neck. And it also looks at some blood work, some maternal hormones. And together, those two parts of that test are put together, and a nice report is sent to your provider that says you're considered at higher risk or lower risk for having a baby with chromosomal abnormalities. And it's the same process. If you're at high risk, genetic counseling is offered. If you're at low risk, then usually you can feel reassured. If you're carrying a twin pregnancy, usually you will only have the nuchal translucency piece of that. The blood work is not as accurate when there are two babies inside the uterus. So that is why your provider might say to you, we're only going to do the ultrasound and not the blood work. Let's get into your second trimester. Now we're in weeks 14 through 28. So here are common discomforts, things you can expect. Round ligament pain, which are the two ligaments that are low in your groin that hold your uterus in place. They never grow in pregnancy. They just stretch to accommodate the growing uterus. So it can cause very sharp stabbing pains, very common, very sort of debilitating initially. And then it's followed by a dull ache for many, many hours after that. Very common, happens to almost everyone at some point in their second trimester. Abdominal discomfort, back pain. I always tell my patients that the nausea goes away just in time for the ripping headaches to start. So you can get headaches usually from somewhere around 14, 15 weeks until about 21 to 22 weeks. They just feel like there's a little mallet at the side of your head. You can wake up with them, you can go to sleep with them, but they're almost always there. You're lucky if you get through your second trimester without any headaches. It's pretty common. Occasionally you can get a little bit dizzy. That just, again, fluid volume changes. Very, very normal, to be expected. Leg cramps, super common. Increase in libido, wanting to have sex all the time, or like closing the shop, don't want to have sex at all. And there's no way to tell which end of the spectrum you're going to fall on. You can get some bleeding when you brush your teeth, swollen or bleeding gums, very normal. Nosebleeds, very common. Stretch marks usually are genetic. So ask your mom if she had stretch marks when she was pregnant. And if she says yes, then I'm sorry, ladies. The likelihood is that you're going to get them too. Constipation and hemorrhoids are super common. So keep, again, going back to your diet, keeping it very rich in fiber rich food, fruits, vegetables, lots of water, keeping your stool soft to kind of help. So what do we do? What do we do in the second trimester? You want to make sure that you're scheduling your anatomy ultrasound. If you're looking to have a more natural birth experience, you want to start thinking, do I want a doula present at my birth? And who do I want? Who do I want that to be? If you go on to Google, which I usually say is like the worst university ever. I tell my patients stay off Google, but if you're looking for something like a doula or buying a refrigerator, right, Google can be really helpful. So I usually say, look for, your county. So we're in Bergen County doulas, and you'll usually get a ton of hits, and then you can visit each one's website. Finding the right doula is just about matching personalities. Because they're all pretty fabulous in my experience. So it's really just what personality sort of, fits with yours. COVID vaccine. I know that's always a question. Should I do it? Should I not do it? It is important to know. I really believe in people should have a choice, as to what they put in their bodies. However, American College of OBGYN does recommend, so does the CDC, recommends a COVID vaccine in pregnancy. Pregnant women who get COVID can be minimally sick to very, very, very sick. So pregnant women are considered at higher risk for developing coronavirus. So it's something to consider. There was a great study that just came out within the last couple months that actually showed that um, babies were getting antibody through breast milk if mom took the COVID vaccine during lactation. So that's something to think about. I think that study came out of the University of Massachusetts. I could be wrong about that, but I think that's where that study came from. You want to start asking around about pediatricians, right? You want to start thinking about childbirth classes. Is this something that I want to do? Do I want to take a childbirth class? Will my partner be interested? A lot of them are virtual right now because of this pandemic that we're all hopefully on the tail end of. You want to start to pay attention to baby's movements, right? Earlier, I said you're going to feel that baby move usually 22, 23, 24 weeks, somewhere in that time frame. If it's your second or third pregnancy, you'll usually feel it a little sooner because you know what it feels like. So you want to start paying attention to movements. You're not going to feel daily movements at 22 or 23 or 24 weeks. You should feel daily movements once you start getting 26, 27, 28 plus weeks. And then continue to exercise, continue to eat well, and remember, continue to hydrate. All right, what are common discomforts in your third trimester? So that's week 29 to delivery. So if you're there right now, it's going to be increased back pain, pelvic pressure. Most of the time I say to my patients, you're going to feel like if you open up your legs, the baby's going to fall out of your vagina. It'd be nice if it were that easy. It's not going to happen, right? Baby's not going to fall out of your vagina, but it feels like it because you're not used to carrying something of that weight, right? So low in your abdomen and into the pelvis. So you do have increased pelvic pressure. You can have lots of increased vaginal discharge in the third trimester, totally normal. Braxton Hicks contractions, those are painless contractions where your belly just gets tight. And it's enough to take your attention away from what you're doing, but not enough to make you think, oh my gosh, maybe I'm having a baby tonight. They're just not that painful. You can have a lot of swelling in your ankles. And if you go on Google, again, it'll make you think that you're dying of high blood pressure disease. And oftentimes you are not. Oftentimes it's just normal swelling that happens in pregnancy. I always say to patients, and I tell mine, and I would tell you the same, that if you're ever concerned, call your provider, right? So a lot of times swelling of the feet and ankles is really normal and it's nothing to be concerned about. But if you're laying awake thinking about it, call your provider and just say, hey, is this normal? Is this anything that I need to worry about? Usually just putting your feet up at night, elevating your feet up on a pillow at night when you sleep will take away that swelling. So you'll wake up in the morning and your ankles will be visible again. And as you're up on your feet all day long, they may not be visible anymore just from the swelling. So you can have lots of difficulty sleeping just from the positional changes of the baby and how much weight you're carrying, shortness of breath, frequent urination, completely normal. So what do we do in the third trimester? Here's what you need to start thinking about. You need to start thinking about a flexible birth plan. Right? What do you want for ideally, what do you want for your labor? Is there anything that you want specifically for your labor? You want to talk about, formulating your plan like post-delivery. Are you going to breastfeed? Are you going to return to work? Are you going to stay home with your baby? Again, finding a pediatrician, that's really important in your third trimester. When you come into the hospital, you're going to be asked, who's your pediatrician? And if you don't have one, you'll be assigned a pediatrician. But what you don't want is somebody who may not take your insurance. So it really is important to have a pediatrician that know who your pediatrician is going to be when you come in labor. Are you going to take a prenatal education class? Third trimester is the time to do that. You want to decide, are you going to breastfeed? Are you going to bottle feed? And then discuss with your partner what your roles are going to be in labor. Sometimes, partners really want to step up, but then they see their wife or their partner in a lot of pain, and they kind of freeze because they've never seen you in pain like that before, and they want to do something about it, but they're really powerless to be able to help. That's where a doula comes in. And that's where I think doulas are really helpful, because they're able to kind of step in. Pain for midwives and doulas and obstetrical providers is like nothing to us. We see it all day, every day. It doesn't phase us. But for you and your partner, it could really throw you guys for a loop, right? Because you've never been in that kind of pain. So discuss what your roles are going to be. Is your partner going to be your support person? Is he going to be more like a cheerleader? Like, you can do this, but maybe you need some more physical support from someone else. Like, those are the things you want to discuss. You want to start thinking about and addressing any concerns that surround anxiety and depression. And I think this is a big one. And I want to spend a minute, and we're almost getting to the end because I want to take questions if you have them. So I really want you to think about, if you struggle with anxiety, or you struggle with depression, and you're someone who says, I don't want to take any medication while I'm pregnant. There's a lot of evidence that says if we struggle with anxiety and depression, and anxiety specifically, the studies say, and we're living with chronic anxiety throughout pregnancy, we actually have an increased risk of producing an offspring, a child that suffers from anxiety too. It's actually less risky to take medication for anxiety specifically. And I would say depression also. So really, it's better to take medication to address those symptoms, right, than it is to suffer with anxiety, for weeks on end. So it's really something you want to start to talk to your healthcare provider about. If you feel like you're having difficulty managing anxiety or depression, there's a huge hormone crash that happens after delivery, and that can exacerbate your symptoms. So if you're feeling it before pregnancy, it's almost guaranteed you're going to feel it afterwards. So you want to make sure that you open up that dialogue with your healthcare provider. And again, you want to keep track of baby's movements, really important in the third trimester, and report any decrease in baby's movements. So labor and delivery, what happens? This is the big day. It's we're waiting all this time for. You want to think about what, false labor versus real labor. So real labor is generally characterized by very regular contractions that are painful. You can't walk or talk through what you're feeling, and it's consistently going on hour after hour after hour. False labor is you have a contraction here, you might have another contraction in a half an hour, you might have another contraction two minutes later, and then not have another one for an hour. So the irregularity of the contractions, and they're generally less painful. So the stronger the contractions get, the more regular they get, the more likely you're in real labor. If you're not sure, again, you call your provider. So early labor is generally, 0 through 3 to 4 centimeters. And the newer guidelines will say early labor actually goes on to 5 to 6 centimeters, and active labor doesn't start until 5 to 6 centimeters. So those of us that have been around for a long time and been doing this, we kind of look at early labor as, 1, 2, 3 centimeters, and active labor is more like 4, 5, 6, even though the definition has changed over the years. So how do we relieve pain if you need pain relief? There's breathing techniques that are usually taught in childbirth classes. Truthfully, you've been breathing since you came out of your mother's uterus. So we all know how to breathe. It's how do we breathe in the presence of discomfort? There's hydrotherapy. Is there a tub where you're delivering? There is at Valley. It's closed right now because of COVID, but non-COVID times it's open. But we have showers in every room at Valley where I deliver babies. So, hydrotherapy is a great way to relieve pain. There's IV pain medication, which can really get you a good hour and a half to 2 hours if you just need a little bit of a break. And then all the way up to the epidural, which makes you numb from usually your bottom of your rib cage all the way down to your legs. So it provides very, very good pain relief if you need it. So delivery positions, I think, are important. It's something to discuss with your provider. Are they open to delivering in different positions? Do you want to push in a squatting position? Do you want to, be on your hands and knees and maybe deliver your baby on your hands and knees? Some people don't even know that there's options. Everybody just thinks it's laying on your back, pulling your knees back, because that's what we see on TV when we watch. But you really can deliver in any position that feels comfortable, provided your provider feels comfortable delivering you in those positions. So that's something you want to talk to them too. And second stage, which is from 10 centimeters until the birth of the baby, like how long does that last? On average, 2 hours, could be 2.5 hours, could be 3 hours. Sometimes if you're lucky, it's an hour, an hour and a half. But I tell everybody to expect 2 hours of pushing, because that's not uncommon. All right, here's questions for your care provider. This is important. How long will you let me go past my due date? If your care provider says to you, okay, well, you're 39 weeks, it's time to have the baby, we're going to schedule an induction, your next question might be, why are we doing that? Is that medically necessary? Do I have to have an induction? Can I just wait for labor to begin? Those are questions that you want to start to open up the lines of communication between you and your care provider if you don't agree with induction at 39 weeks. If it's your first baby and you're being induced at 39 weeks just because, I would tell you that might increase your risk for cesarean section. So those are things that you want to kind of, talk to your provider about. Can I deliver in any position I want, or do I need to be on my back? What positions are you comfortable delivering me in? Can I use the shower while I'm in labor? Do I have to be continuously monitored? There are some care providers that feel like their patients need to be on the fetal monitor the entire length of time that they're in labor. So it doesn't give you much flexibility in terms of what you can do. So you want to make sure you have, that question answered for you. And who is going to be at the hospital to deliver my baby? A lot of care providers are in a larger call rotation of many, many people. So the person who you see in the office may not be the person who delivers your baby. So that's, you want to get that clarified as well. That's a good question to ask your provider. So here are the most common questions that I get. I'm going to breeze through them, and then we'll take maybe 15 minutes or so to answer your questions. Can I drink coffee during pregnancy? Yes, you can have 8 ounces of anything caffeinated in pregnancy. Can I eat sushi during pregnancy? I tell my patients nothing raw, right? No raw fish, no raw meat, nothing raw. So if you want to have some cooked rolls, totally fine. What products can I use on my face? So most of the over-the-counter products are okay. You want to stay away from retinol, any retinol containing products. You want to double check with your care provider. Sometimes I just tell people, take a picture of what you normally use, and I'll tell you if it's okay. What type of exercise can I do? Pretty much anything that you were doing before you were pregnant, you can continue to do, provided it doesn't put you at risk for fall. So I tell my patients, no skiing, right? No rock climbing. Makes sense, right? Things that you could put you at risk for fall, I prefer that my patients not do. Can you go swimming while you're pregnant? Of course, absolutely. When should I stop working? So that's really based on your financial situation and your comfort level. Some women work all the way up to 40 weeks. In the state of New Jersey, you can actually go out on disability at 36 weeks just because you're pregnant. State of New York does not have those same rules. So state of New York does not recognize disability unless it's an actual medical condition. Pregnancy is not considered a disability in the state of New York, right? Boo-hoo. Can I lift weights while pregnant? Yes, I usually tell my patients to cut their weights in half, so they're not straining at all while they're lifting. Can I do CrossFit as long as your instructor knows that you're pregnant and you can make the appropriate modifications? Yes. Can you do spinning classes? Yes. Can you do yoga? A resounding yes, just no inversions, so no headstands in a yoga class. What if my baby doesn't come by my due date? Question for your provider. Usually we look at induction, at least as a midwife, I tell my patients there's no increased risk to you or the baby for a week past your due date until you hit 41 weeks. And that does vary based on your age. So if you are 40 or over, the recommendation is to be delivered by 39 weeks. If you are 35 to 40, you do have a little bit more flexibility. And if you're under 35, you have that same flexibility as the 35 to 40 age group. Of 40, and some providers would say 38, 39, 40. It is a little bit more common for the to have placental complications where The placenta doesn't function as well as it does, prior to age 35. And that's one of the reasons why we talk to women about, getting delivered at 39 weeks or at least by 40 weeks. And then, how do you induce labor? Generally, we use a medication called Cytotec, which is a pill given every 4 hours, and we do that the night before an induction. We can use a little suppository called Cervidil, which is something that's done the night before that goes in the vagina, stays in for 12 hours. You would be in the hospital at that point. And then the following day, we would use Pitocin. So Pitocin is a synthetic form of the hormone oxytocin. Since Pitocin is not horrible, I think it actually saves people a C-section sometimes, because if people are contracting irregularly and they need a little bit of help, Pitocin is that help. So talk to your doctor about, how he or she would induce your labor if necessary. So these are some of the most common questions, but I would love to know what your questions are. If you have any questions for me, please let me know what those are, and I am happy to answer those. I wanted to give you a brief overview, and I'd love to hear any of your questions.
Great. Thank you so much. That was super informative. So I do have a few questions that came in. If you have more questions, throw them into the chat, people, or the Q&A, and we'll get right to them. So do you recommend a doula for all of your patients?
So anyone who wants to have their baby naturally, or isn't quite sure, like maybe I want to try to go as long as I can before I get an epidural, I think that a doula is really, really helpful to get you there. In my experience, and again, I've been doing this almost 30 years, patients who don't have a doula, who are not sure whether they want to go naturally or have an epidural, will almost always opt for the epidural a lot earlier than if a doula is present. So it's not that I recommend them for all patients, because there's a financial consideration too, right? Doulas aren't cheap. So it's something that you have to research. Does it fit into your financial profile? Is that something that you can afford? Is it something that maybe your family might chip in for and help you with? So I think that, there's creative ways. There's doulas that have payment plans. So it's something to kind of, talk to doulas about. I don't recommend them for everyone. If somebody says, I know I want an epidural, that's how I had my last 2 children. Is a doula necessary? No, I don't think it's necessary in that situation.
Great. What extra precautions should I take as a pregnant woman during COVID?
So, being pregnant during COVID isn't that much different than being pregnant outside of COVID, right? Because babies are very well protected in utero. So it's really protecting yourself. It's good hand washing hygiene. It's probably not necessarily going to like the concert that you're dying to go to because nobody's been able to be outside of the house, or, going to like, an indoor, I don't know, basketball game, hockey game, where there's a lot of people indoors. I think right now during COVID, it's probably better to, if you're going to be with a group of people, to stick with things that are outdoors. Mask wearing, the science around mask wearing, everybody has their opinion about that, but still right now, it's probably one of the better ways to try to reduce transmission. And then getting that vaccine. And I know that that's so controversial for so many pregnant women, but so many of my patients in the beginning didn't want to get the COVID vaccine before it was FDA approved. And I understood that and I supported that. But now that it's FDA approved and I'm seeing more and more women vaccinate with almost no complications. If you look, 178 million people in this country have been vaccinated. And if you look at the VAERS website, which is the adverse event reporting website, there's like 5,000 complications. 178 million, 5,000 complications. So when you look at that from a percentage standpoint, this vaccine is very, very, very safe. So that is probably, number one. And I understand when people don't want to do it, but really, if you're asking my opinion, I would tell you there it is. And I'm a midwife and I'm really about natural stuff, but we do know that that really does protect people from getting very, very sick.
Awesome. Do you work with high-risk pregnancies?
So as a midwife, there are, yes, my entire career has been in high risk. And that's just sort of the way that it panned out for me. I didn't go in expecting to be in high risk, but I was fortunate enough to practice with some really fabulous physicians and work with high risk pregnancies. So it depends on the level of risk. There are certainly patients who risk out of midwifery care. So patients who have like a history of heart disease, you're better cared for by a physician. If someone ends up comes into pregnancy as a brittle insulin dependent diabetic, that can really require medical management. So that's somebody who I would say is more suited for medical care. But do we manage certain high risk situations? Yeah, I mean, high blood pressure, sure, midwives manage that. If it's high blood pressure on two or more medications, non-pregnant, I would say that's a physician patient, right? So when patients come to a midwife, generally I'll ask for their medical history. We'll talk briefly about any medications they're taking, and then we kind of determine, are you appropriate for midwifery care, or are you really better suited to be managed by a physician?
Great. Okay, and I have one more question here that came in. If anybody else has more, send them in. Can I breastfeed my first child while pregnant?
It's a great question. So, it's funny because I know a lot of doctors that would say, no, absolutely, you cannot, because that can cause some cramping or contractions. And while that's true, it can cause cramping or contractions. Breastfeeding has never been known to actually cause labor. So I do tell my patients that you are absolutely free to breastfeed an older child, provided that you're not getting painful contractions, right? So you have to kind of use your common sense here. So if you're breastfeeding and you're getting really strong pains, uterine contractions while you're breastfeeding, that may be your body saying that breastfeeding might be a little bit too much, right? We have to kind of just listen to what our body tells us. As a general rule, most babies that are nursing, when their moms become pregnant, they almost always self wean, because the milk actually starts to taste a little bit different. So we're in a country where we don't have to rely on breast milk for nutrition if we need to. For example, in countries where there's famine, right, children breastfeed for a very, very long time, really, into their early education years, 5, 6, 7, 8, 9, in countries where there's a lot of famine because there's just not enough food. In this country, food is plentiful for most people. So if you needed to stop breastfeeding because you were having strong contractions, your baby won't starve, right? So you have to just kind of use your head. In general, I say it's safe. Anyone who has a history of preterm labor in a previous pregnancy, nursing may be an issue, in a future pregnancy. So being pregnant and nursing that child, if that child was born preterm, does that make sense when I say that way? Yeah, that may be something that may cause a provider to say to you, you know what, maybe you need to back off on that. But as a general rule, it is considered safe.
Great.